Dr. Lisa Armitage. Dr. Armitage is a board-certified infectious disease physician and is board-certified in internal medicine and pediatrics. She has worked for several years in the field of TB and serves as Assistant Medical Director for Heartland National TB Center. She obtained her PhD in molecular pathology and is currently involved in clinical research to improve treatment outcomes of TB patients. Please welcome Dr. Lisa Armitage.
I'm sharing the wrong one.
No, you're sharing screen number 2.
Okay. Well, good morning, good afternoon, and good evening to our panel physicians from around the globe, and thank you for joining us today. We have a really exciting series to share with you, and some really some of our the best our country has to offer with regard to pediatric TB specialists. So as a whole, we're very excited to be producing the webcast and to have you joining us. We are aiming for, at the end of each of the sessions, to have some time for you to be able to have some voice and to see if there are any questions that you have. So the first session we wanted to start with, since we're talking about focusing on pediatrics and pregnant ladies, we wanted to start with what the technical instructions for panel physicians recommend. So first, I want to say I have no conflicts to disclose and no relevant financial relationships with any of the partners. And we do want to say thank you to the Division of Global Migration and Quarantine for allowing us to speak with you in block about the topic. So today I want to describe the CDC TB technical instructions for TB with the updates that came as of 2019. We want to explain the application for TIs for TB screening specifically, since there are many things that our panel physicians are tasked with screening for overseas. Want to focus with what the TB screening involves. Want to explain the application of the TIs for directly observed therapy, and then to describe the guidelines for clearance for travel, which is usually at the top of the list of wants for the individuals that are applying for entry. And then also want to discuss the impact on the U.S. TB care after implementation of the TIs. So here's the document that I will be discussing, and I went to the site just recently to note that they have the last update was October 17th of 2019. So that will be the information that's contained within the document, and that will be where we will start our discussions. So as I noted, the panel physicians are tasked with many technical instructions, and I just wanted to line out for those who are visiting from the U.S. side to understand the things that the panel physicians are being asked to screen for are multiple examinations. And so tuberculosis is one of the ones that the panel physicians are tasked with screening for. The medical screening overseas. So the Centers for Disease Control, and specifically the United States Public Health Services are responsible for ensuring that non-citizens that are entering the U.S. do not pose a threat to the public health of our country. So we say that our new countrymen, when they join us, we want to make sure that we're screening them and helping them to make sure that they have their screen for anything that they may have that is infectious. And the medical exam required by the CDC regulations is basically a means of evaluating the health of individuals that are applying for entry. So panel physicians. Panel physicians are defined as medically trained, licensed, and experienced medical doctors who are practicing overseas. They're appointed by their local U.S. embassy or consulate. And to date, there are over 760 panel physicians who perform the overseas departure and medical exams in accordance with the technical instructions as I showed. And these instructions are provided by the CDC and the Division of Global Migration and Quarantine Quality Assessment Program. So I was able to sit on one of the guidelines updates committee, and it is really a very motivated group of individuals who are not only trying to give good guidance to the panel physicians overseas, but also being mindful of the individuals that are trying to immigrate and make sure things are not, too burdensome. These medical professionals, our panel physicians, receive U.S. immigration focused training in order to provide examinations that are required by the CDC and also by the U.S. Citizenship and Immigration Services. So based on the understanding that the medical screening for TB is essential is this essential component for the medical evaluations, this is where the TI step in. But it's important to note that a little bit different from what we do here in the US, the emphasis for the pre-immigration medical evaluation is on infectiousness. And as we're doing an entire series on children frequently are non-infectious. So there tend to have to be different ways of evaluating them during the screening to look for ways to not only keep the child safe, but also to meet the requirements for for entry into the US. So the diseases of the lung parenchyma, pleura, larynx, and the intrathoracic lymph nodes, this is what is considered, tuberculosis disease. So patients who have disease in these particular areas in the body are considered potentially infectious. Now, extrapulmonary tuberculosis and latent tuberculosis infection, while we may consider them disease, they're not considered, TB disease for the purposes of these technical instructions. So the instructions define the specific responsibilities of the panel physicians in terms of testing and treatment, and then also for reporting for the patients who are medically eligible to enter the US. A little background, I took this from a paper that came out that looked at the difference when sputum smear and culture was added to the overseas screening. And in addition to that, I'll share some information on what happened when we added the IGRAs for children. But let's start with just, each year there's about 450,000 immigrants, about 70,000 refugees. This number will vacillate, obviously, enter the US after being screened at a panel site. So technical instructions from 1991 only required a chest x-ray for individuals that were greater than 15 years of age. So they were age 15 or older, they only required to have a chest x-ray. Later analysis showed this to be sensitive in picking up only about a third of cases. So this was pretty much 2/3 of individuals that actually had active disease were somehow being missed. So about 1,100 cases of TB were diagnosed, and they just looked at 2012 in their overseas exam. About 60% of these were smear negative and culture positive. So of these cases, 14 were MDR. So basically what they found was just by adding the sputum addition, that there was successful implementation of this part of the screening program was able to save the US in excess of $15 million annually in treatment. More facts. This was a study that was looked at a group right across the border from us in Mexico. We're here in Texas, and they're right across the border in Mexico. They did a retrospective study of their records from 122 patients that had active TB in their clinic, and their clinic was Clínica Médico International. And they just looked at from 2009 to 2012, again, the same period of time we were looking at previously. And all of their cases that they chose for the 122 patients, 80% of them were, they were all culture confirmed, but 80% were smeared negative and 20% were smear positive. So basically what they found was 8 out of 10 of their cases would have been missed if they had not collected sputum for smear and culture. So they did note that almost everyone in their evaluation said that they were asymptomatic. So I'm sure that there maybe have some who have symptoms, but maybe they were not considering them at the level that they would have drawn attention to get the sputum. So, that just adding in with an abnormal chest x-ray, the addition of getting smear culture has been a very big advancement in what we're doing, what the panel physicians are doing. So a complete screening exam. So we're talking about TB screening as defined in the technical instructions. These involve a medical history, physical exam, and IGRA when required, and this is in children now a new requirement. Sputum for AFB smear and culture testing, and for Mycobacterium tuberculosis. So we're doing sputum for acid-fast bacilli, smear and culture, which will get you to the Mycobacterium stage, but then there's a requirement for speciation down to Mycobacterium tuberculosis, at least MTB complex. And of note, HIV is no longer part of the US medical screening process. The medical history. So this is focused on risk factors for TB disease. So a history of TB disease, or whether there are current illnesses suggestive of TB disease, a cough lasting longer than 3 months, it's specifically a long-lasting productive cough, fevers, chills, night sweats, the symptoms of ongoing chronic disease, having some prior evaluation suggestive of TB. And so I want to note that the panel physicians, we asked that if you had questions that you forward them to us. And I want to say thank you for that. So we will be trying to weave those in, and we will provide the ones that are relevant to other topics that are coming in the future. We will make sure that the individuals who are giving those talks are aware of your questions. But one of them that came up for my section was the question, how far back do you have to ask about, history of TB disease? And I would say you want to know whether that person had TB disease ever. That's going to flavor how the evaluation goes. If there is an old scar or old calcified nodules in the chest, for example, and you know that person had a history of active disease and was adequately treated, those are kind of what I call scars from an old fight, but less likely to represent current active disease. So I would say history of tuberculosis disease ever, essentially. And then you're asking for any suggestion of current disease and or any symptoms of active disease. You want to know prior diagnostic evaluation suggestive of TB disease. If they tell you they had a chest tube, for example, but they quote never found anything, or if they tell you that they had a cough for a long period of time, and they did some evaluations for sputum, or they did some evaluations for imaging around the chest, that would pique your interest, as this could have been previously undiagnosed tuberculosis. But know that this focus on risk factors and history can be very different for children. So we're going to talk a lot more about TB presentation in children in one of our sessions. But know that things that you want a person who knows that child, that can be present to give a history. You want to know if that child is losing weight. You want to know if that child is more listless or more sleepy, or just failing to thrive, not eating well. These are all things that are more suggestive of TB in infants, for example, than the classic chest x-ray finding in cavities. So you want to inquire about about family members or household contacts to someone with TB disease. So this is from adults down to children, especially relevant in children. Frequently, you don't have a lot of the focus of disease is very different, or you don't have a reason for a child to make your radar about TB unless they're in the household with someone who has active disease. So this is a big point. And when you're evaluating children, you want to know about extended family, aunts, uncles, grandparents, babysitters, anyone who took care of that child outside of the home and that was known to have active disease, and ask that question. History of BCG vaccination. This does not change how you read the TST, but it is something that is taken into consideration since there is some false positivity rate from BCG with the TST. So I will throw the question out, and I didn't ask it as an audience polling question, but if you, the NHANES data actually looked at all comers, individuals who were entering the US. They were tested by both IGRAs, the T-spot and the quantiferon, and the TST. And so the question, if you ask a person who's BCG vaccinated, many of them have been taught that they will be TST positive for life. Such was not the case. Persistent TST positivity was around 17 to 20%. So let's just say about 20, 1 in 5 individuals will remain TST positive, but many of them, the TST findings will fade. So you still want to know, the younger you are and the closer you are to having received that BCG vaccination, the more relevant it's going to be. But if the history of TB is, if they had a history of TB, but now they have a normal chest x-ray, they have no current signs or symptoms, and they're not known to be HIV positive, then they would receive a classification of no TB classification. The physical exam, standard measurements: height, weight, temperature, heart rate, and blood pressure. For children, height and weight is a really important assessment. So children who are smaller than the other siblings and perhaps, seem to be less vigorous than their siblings, or multiple siblings in a household that are also failing to thrive. Malnutrition is something that needs to be considered, but also knowing that a child is falling off of the growth curve is important, because that is one of the signs that TB may be a player. Temperature, persistent fevers, especially children who have meningitis will especially have persistent fevers, as well as behavioral changes, whether it be more somnolence or sleepiness. Pulmonary exam, very important. Lymph nodes in a smaller chest can cause some narrowing of the airways. So listening for extraneous lung sounds is important. If you hear some, to follow them up with a chest x-ray. Inspection and palpation of lymph nodes, babies and toddlers and younger children. Scrofula, more common in this age group. So something else to be considered. And then inspection for scars of scrofula or prior chest surgery. Again, these could represent prior untreated TB disease. So IGRAs. IGRAs were added in. Now, applicants that are ages 2 through 14 years of age in countries with TB incidence of greater than 20 per 100,000 cases of TB per year must have an IGRA. There is specifically no mention of one IGRA over the other, whether the quantiferon, what's available now, the quantiferon plus, or the T-spot TB. Either test should be considered adequate. The exceptions to required testing with an IGRA: written documentation of a prior positive IGRA. And if there's written documentation, it must include the date, the type, it must the result in standard units, and the interpretation and the testing physician information. So there must be, it can't just be a verbal that they had a prior positive. That must have all of the information included to otherwise it's best to just repeat the test. And then also, if there is documentation of previous TB disease, there is no need for an IGRA in that population. An indeterminate, the indeterminates seem to have lessened somewhat as the quality of the tests have improved over time. So an indeterminate, should you have one, should be documented as such. There is no requirement for retesting by the panel physician, or there's no requirement for a chest x-ray or a B2 classification. It should just be designated as an indeterminate. The applicant should be advised to have it repeated when they reach the US on arrival. So if that can be included in the paperwork, or at least told to the parents so that they know that that's the expectation. The TST can only be substituted If an IGRA is not available in the country of where the individual is being tested for entry into the US, or if the child is less than 2 years of age, then you can use an IGRA then. But I will tell you, by the end of this session, the 6 sessions, we will probably have convinced you that you may want to consider an IGRA in a child less than 2 as well, if there's any chance that you're not being able to place or read the skin test. So the question came up, you noted that a lot of the data is divided into whether a lot of the evaluation is divided into whether the individual is from a country with a higher rate of TB that is 20 cases per 100,000 individuals in that country versus less than 20. So greater than or equal to 20 TB cases per year per 100,000 or less than. So for us, I'm sure if it is your country that you're screening from, it's easy to say, but if you have an individual who is coming to you and is perhaps immigrating from somewhere else, and you think maybe their risk had come with them from that country versus your own, then one place that you can find where the rates are for the individual cases is here at the World Health Organization, because that is the World Health Organization designation of cases per 100,000 is the one that the screening for individuals outside of the US to come in are based on. So the technical instructions are divided based on the findings here. The global report has the entire report, but there is there is TB country, regional, and global profiles that you can use as well. And I wanted to show some examples. I chose the top 3 countries that we have that are where we have immigrants from to the US. And I started with Mexico as our neighbors to the south, who have the largest number. And if you look at the rate per 100,000 population of TB, total TB incidence is 24 for Mexico, for example. The Philippines, 539, and India is 188. So it varies by country and by region, but this is one way that can be determined whether what the actual rates are for the individual countries. Important to note, HIV is no longer part of the panel physician's screening process. Panel physicians may advise applicants about HIV testing if the panel physician feels it is indicated. So in cases where you have diagnosed active TB disease and you feel that this may impact the length of treatment or how you treat the patient, whether we know that patients who have both HIV and TB do better if both diseases are treated. So if their HIV is treated and their TB is treated, they tend to do better overall with decreased mortality. So if a panel physician feels that HIV testing is warranted, you can advise the applicant of this. But patients who receive HIV testing must consent to the HIV testing. And the consent should include documentation that they understand that they do not have to be tested. They also understand that if tested, they do not have to be tested by the panel physician. They can be tested in a facility of their choice. And they should also understand that HIV results will need to be included in their paperwork if these results are known. So all HIV infected applicants must produce sputum for smear and culture, regardless of what your chest X-ray or IGRA results show. Chest X-rays. Most, there's probably a divide some in the US, but most of us pediatricians prefer a PA or an AP and a lateral. So lymphadenopathy, intrathoracic lymphadenopathy is much more easily assessed in patients who have both views. And so you will see that kind of leaks over for, at least for myself, into not just children, but also into adults. When I'm trying to get a good assessment of where a lesion is and what a lesion is, The having a lateral exam is extraordinarily useful, but it's important to note that for the technical instructions, you're only required to have a lateral exam in children who are less than 10 years of age. So if a child is greater than or equal to 10 years of age, you can do just a posterior anterior view. Now, the chest x-rays now must be interpreted by a radiologist and reviewed by the panel physician. I will say that no person is perfect. So having two reads increases the sensitivity that if there is something that needs to be picked up, it will be. Skipping to the last point, it must be the radiography now must be digital. So gone are the days where we used to have individuals that would come into the country and bring their films with them. Now having them digitally allows for the patient to transfer with a disc, and also gives a little bit more flexibility once we receive our applicants here in the US to be able to review the films from overseas. So the pregnant ladies, we're going to have some talk about the pregnant ladies, but I wanted to start off our first session speaking. Women who are pregnant may postpone their chest x-ray until after pregnancy, but they must have one before immigration. And they must consent for if they're going to have, a pregnant woman is going to have a chest x-ray, she must consent for imaging and must be provided a lead apron that covers her like all the way around circumferentially. But I wanted to point out one piece of information. So this is from the American College of Obstetrics and Gynecology, and the paper was an opinion paper about using radiology in pregnancy. And so this is just one table from deep inside. Well, I won't say deep, but it was table 3, where they looked at the fetal radiation doses that were associated with common radiographic examinations. And the chest x-ray, way down here, a 2-view chest x-ray has one of the lowest exposures. So they're considered safe. So you can reassure a pregnant lady if you have some concerns after you've done your exam, if you're listening to her chest, you have some concerns that she may have active disease and you want to confirm or to take your exam further, I would say that you can say confidently to this woman that a chest x-ray is not going to cause harm to her or to her unborn child, and consider actually getting it done. I will say that if there's nothing about TB that makes it nice enough to spare the pregnant ladies. So if you have a pregnant woman and she has family at home and she has active disease, then there's a good chance that she could be infecting her family or other children that she may have. So diagnosing TB in the pregnant ladies is important, not only for the child that she's carrying, not only for the mom, but also for her community and her family. So just one little tidbit to let you know that at least if you're getting the radiographs, they are safe. Sputum. Must have at least 3 sputum specimens. This is important. So I have some data on why the 3 specimens, but the requirements are early morning fasting. They must be directly observed. I tell people all the time, nobody is born knowing how to produce a good quality sputum. So having someone to coach you through it, very important. If you're highly suspicious this person may have TB, please have a safe place to do this, whether it be outside your clinic, in a nice shady area is always nice, or have a room that is contained that has a negative pressure room. But at the very least, somewhere outside so everyone's kept safe. The specimen should be 5 to 10 cc's each and at least 24 hours apart. The sputum can be induced, but if it is, let the laboratory know so they don't throw it out as being too thin or being saliva, because generally when you're inducing a sputum, you're having to bring up, you're inhaling, saline, and then you're coughing the specimen back out. I will say, and I will ask our trainers to put in the the chat box, but one thing that we found on ours is individuals, so people who are unable to produce a sputum. It's really hard. They will tell you, I don't, like my cough is dry. I don't have a cough. It's really difficult for them. So there are some very nice videos on YouTube on Huff Cough, and it's HUFF cough. And they give a lot of good tutorials on how to coach a person to give a good sputum. This might work well in smaller, and I would say in young teens, perhaps. We I find that the boys are really excited to hawk up a loogie, as we say, and produce a lot of sputum and have no problem doing that. But if you have a child who is struggling a little bit, showing them the video and perhaps giving them some, coaching on how to get a specimen out. Gastric aspirates can be used for all ages, but it is noted that sputum is preferred in older children and adults. So really working with them to be able to produce a sputum is really important. But in addition, gastric aspirates start playing much greater role in infants and toddlers and small children where TB disease is a suspicion, but you can also use bronchoscopy. So sputum specimens should be submitted for smear microscopy for acid-fast bacilli, culture for mycobacteria, and then some drug susceptibility testing for all cultures that are positive. But here's the data I wanted to show you. This is a paper that was produced a while ago. And this actually was a group of individuals that were immigrating to the US. They chose 79 subjects that agreed to participate, and they collected 5 specimens from each of them. So the individuals did, a sputum. These were in the first day, 8 hours apart. So, first, second, and third specimens were 8 hours each in the first day. And then there was a specimen collected first thing in the morning on the second day, and then another one collected first thing in the morning on the third day. And they compared what their culture positivity rate was for these individuals, and then compared that to group 3 gastric aspirates and a single bronchoalveolar lavage. So if you can get a person to give you a good, these were all induced sputums, by the way, but if you can get a person to give you a good quality specimen, you can reach very high, rates of positivity compared to more invasive techniques if you're able to work with them to give you a specimen. So the culture and drug susceptibility testing. Solid and liquid cultures must be performed on both. So the liquid cultures must be held for at least 6 weeks, and the solid cultures have to be held for at least 8 weeks. If they're positive, the organism has to be identified down to the level of a M. tuberculosis complex. So if it's non-tuberculous mycobacteria, you do not have to, there's no need for additional analysis. If it's non-tuberculous mycobacteria, that is the designation. But if it is considered in the MTB complex, you need to just get down to that. And that includes Mycobacterium tuberculosis, Mycobacterium bovis, Canneti, Microti, so some of the more rare ones, but at least down to what's primarily what we see is M. tuberculosis and M. bovis. So positive cultures must have drug susceptibility testing to at least the first line drugs, isoniazid, rifampin, ethambutol, pyrazinamide, and then another requirement, streptomycin. So rifampin resistant cultures must have second line testing to at least ethionamide, fluoroquinolone. That can be moxifloxacin, levofloxacin, ofloxacin, like any of the 3, and then amikacin, capryomycin, and PAS. Now the most recent World Health Organization guidelines, and to some extent there's an evolution in the US guidelines as well, to move the injectables out of treatment for rifampin and resistant disease and multi-drug resistant disease. So stay tuned. You'll probably see some change in what the in the testing requirements going forward. Panel physicians can use Gene Expert, the Gene Expert MTB RIF or the Gene Expert MTB RIF Ultra. I will say that the Ultra is not available in the US. For now, it's there are a lot of really good things around that particular test. So we're a little jealous here, but it's a good test. But you can also use tests such as the Hain test, that looking for drug resistance. But these tests should be noted, can only be used by the panel physician if they have regulatory approval in their country. So another, that one thing I wanted to interject here, and all of the screening and the sputum and the testing, it's working. So this was a paper that was just published actually earlier this month, looking at multi-drug resistant TB in US bound immigrants and refugees. So they looked at the culture, so the culture-based overseas TB screening and immigrants and refugees prevented 24.4 multi-drug resistant TB cases per year from arriving in the US over the period that they were examining. And that's 18.2 cases more than smear-based overseas TB screening. So we're seeing impact of the actual of the screening and the treating overseas. So I think I have the same bullet twice, but the take home was that culture-based overseas TB screening in US bound immigrants and refugees substantially reduced the importation of MDR TB in the US. I'm sure that second bullet was probably something important. I'll get it back to you later, but I apologize for the miss. So now we're looking at the applicants, and as I told you before, how you screen depends on the incidence of TB in the country. So for individuals from what's considered low incidence countries, where there are less than 20 cases of tuberculosis per 100,000 population, individuals who are less than 15 years of age, so they are children, require a physical exam and a history. Those with signs or symptoms suggestive of TB disease should have an IGRA and a chest x-ray, and then provide 3 sputum specimens. So it starts with, and then from the low incidence countries, only a physical exam and history in children less than 15 years of age. You escalate to additional testing. If you see signs or symptoms suggestive of TB disease, then you would add in an IGRA, a chest x-ray, and provide 3 sputum specimens. So now for individuals over 15 years of age, you will see this same thing come out, regardless of what the incidence in the country is. The initial evaluation, the TB screening, involves a medical history, physical exam, and a chest x-ray. So that is for all individuals that are at least 15 years of age. Those with signs or symptoms of TB or who are known to have HIV then must also provide sputum for AFB smear and culture. So now the difference in looking at children, so we're now focusing just on little ones, less than 2 years of age. So in countries where there are high incidence countries, more than 20 TB cases per 100,000 population, then you're required to do a physical exam and a history. But those with signs or symptoms of active disease or known HIV must also have an IGRA or a TST. And note there that you can substitute in a TST, but if you can do an IGRA, you can do an IGRA on a child less than 2. The reference that they give for that is the American Academy of Pediatrics Red Book, where it does line out why there are some reasons why many of the experts here will use an IGRA in addition to, or often in place of, the TST. TST reading is getting to be a lost art. It's getting to be a smaller number of people who actually can do them and do them well as people get older and people retire. And the IGRA gives you a more objective reading of assessment of TB infection for a child. But anyway, also they must have a chest x-ray, and then they must provide, we say 3 sputums, but that would likely be in the form of a gastric aspirate. Or if you can induce sputum on a toddler, there are some videos that are available, and we will address that when we get to assessment of small children. Then you can also induce a sputum from a small child if you are doing it or do a gastric, but there must be 3 respiratory specimens that are provided. Now, applicants from higher incidence countries that are between the ages of 2 to 14 years of age must have an IGRA. You have to perform an IGRA. Remember, the only times when you can say that when you do not have to do it is if there is documentation that they had one previously or a documentation of prior active disease. So if the IGRA is positive, if there are signs or symptoms of active disease, or if they are known to be HIV and they are known to have HIV infection, the applicant must have a chest x-ray. Those with a chest x-ray suggestive of active disease or who have signs and symptoms of active TB disease or known HIV must provide 3 sputum specimens. Again, this can be gastric aspirates. This can be induced sputum in a toddler, but preferably in older children, try to induce sputum from them. So the new addition of the IGRAs, how has this impacted what we see in on this side? We know that, latent TB infection, over the course of one's lifetime, there is there's about a 10% chance that you will progress to active disease. This is what the literature has told us for years, is that just all comers, if we screen every individual, regardless of risk factors, who has, and they have LTBI, they have latent TB infection, they have about a 10% chance of progressing to active disease. This is very different in different populations. Children under a year of age, 50% chance of progression. Children who are 2 and older, or who are 1 to 2 years old, 25%. Goes down as they, get over 5, but it's still treatment for LTBI in young children, especially, is a decreases their lifetime chance of progression to active disease. But know that all of that 10% that we've all learned and has been engraved in our head is not the same for small children. And we'll have more on that when our session on screening in children and screening for active disease, and using the test. We will have more on that. But I wanted to point out, if you look at the left panel, this is where children whose medical exam was performed in the time before the IGRAs were required. And then over on the right side is the outcomes of the children who were screened after the TI is required that they have an IGRA. And the first thing that you notice with, a confirmed overseas LTBI diagnosis, that was, the drop from what was confirmed overseas to recommended treatment, you lost about 25% of children that would have been treated. And I think this is a lot to do with the fact that everyone thought that the TST was due to BCG, and no one really recommended the children go forward for treatment. And so once we have an IGRA, which does not have that baggage of a false positive rate, you see a significantly decreased drop. Well, that sounds funny, a decreased drop, but you see a lot less, a lot smaller number of individuals are lost. Most of them are referred or recommended to get LTBI treatment. There was a little bit less, accepting and starting treatment seemed to be, for some reason, did not progress as well. Very similar numbers that once they started completed treatment. But the take home is that when under the old TIs, only about 35% of children who were, diagnosed as having LTBI actually got treated, whereas this increased to almost 60% when we started adding in the IGRAs as a screening tool. So I will say that it's probably another layer of something that must be done to our panel physician colleagues overseas, but it has made a significant impact on getting children into care and getting them treated. So just to reiterate, I did the verbiage, but we'll look at the algorithm for TB screening of 2 to 4 year olds. In low burden countries, this starts with a medical history and a physical exam. If on the evaluation by the panel physician, there are signs or symptoms of tuberculosis or known HIV infection, then that child would then receive an IGRA, a chest x-ray, and produce 3 sputum or gastric or bronchoscopy specimens or induced sputum, but they would need 3 respiratory specimens at that point. And for those who have positive cultures, then you would require drug susceptibility testing. So that is the algorithm for children in low burden countries. But if you look at high burden countries, the IGRA moves up into the initial evaluation. So you have medical history, physical exam, and IGRA thrown in. And only if you have a positive IGRA or signs and symptoms of tuberculosis or known HIV infection, would you then add a chest x-ray. And only if you have chest x-ray findings, then would you add the 3 sputums. And then you would also, for positive cultures, have to do a drug susceptibility test. So the onus looking for infection is a little bit lower in the low burden countries. So the chest x-ray, again, for those who are greater than 15 years of age, chest x-ray, must have a chest x-ray and a history. Those with a chest x-ray suggestive of active TB disease or have signs of symptoms of active TB disease or who are known HIV positive must produce 3 sputum specimens. And what you find here is basically whether they're in a low burden country or a high burden country, the evaluation is essentially the same. There's not the requirement for an IGRA, which is helping us get younger kids into care and into treatment on the other end. But for every applicant over 15 years of age, I would say greater than or equal to 15 years of age, then they're required to have a medical history, a physical exam, and a chest x-ray. So again, why the difference? The difference is that the focus is infectiousness. And so this is why the chest x-ray moves into the first assessment for all individuals who are potentially infectious. Children less than 10, there are some kids that in the US, there are some 10-year-olds that are almost as large as an adult, so looking at how large a kid is and what their lung capacity are, most children though are not infectious, especially under the age of 10 or 12 years old. We'll talk about, there was one of the panel physicians submitted a question about infectiousness. We will cover that and promise you that we will go do a deeper dive into all of these things. So for those individuals who have either symptoms on the medical history, when they have some signs or symptoms suggestive of TB, or they have HIV, or they have physical findings. Remember, lymphadenopathy is extrapulmonary TB is not considered as active TB, but if there's evidence of extrapulmonary TB, you have to get a chest x-ray on those individuals, even on children, but also you're looking for that in adults. And then if you have an individual that has a negative chest x-ray, but still has either signs of symptoms of TB or has evidence of extrapulmonary TB, regardless, they have to produce 3 sputum for you, and they have to be sent for culture. And then again, positive cultures have to undergo drug susceptibility testing. So now, the classifications. Always some of the most important thing for how an individual is managed when they reach the US side. So, the simplest one is no TB classification. This is an individual that is not have documentation of having HIV. They have no current findings to suggest active TB on your physical exam or on your history. They have negative negative IGRA and a negative chest x-ray. So again, the IGRA is only for a requirement for children that are 2 to 14, but that's where the negative IGRA is there. But if you have an adult and for some reason they had an IGRA and it's negative, normal chest x-ray, then they get a classification of no TB classification, and their travel clearance is valid for up to 6 months. If they do not travel within the 6 months, then they have to repeat the evaluation just to make sure that nothing new has happened. The Class A TB disease, also rather simple. These are individuals with tuberculosis disease. This can include extrapulmonary disease with a chest x-ray suggestive of TB disease. Remember, extrapulmonary disease in and of itself is not considered TB disease unless it's, in the lung parenchyma, the pleura, the intrathoracic lymph nodes, and laryngeal disease. So if they have a chest x-ray suggestive of TB disease, regardless of the smear or culture, then they are considered as having TB disease, and they're not cleared for travel until they have had a full course of treatment as required by, the TIs go very specifically into treatment. Has to be a US approved treatment and also done under directly observed therapy. In these individuals, we'll talk about waivers, but you can request a waiver if there is some compelling reason. If you have, for example, a child that cannot get the treatment that they need where they are, or they can get better treatment here, or there's some compelling reason why the family needs to travel, you can request a waiver. So the Class B0 TB, pulmonary, these are individuals that are diagnosed with active TB by the panel physician or who present to the panel physician already on treatment by another provider. And these individuals must successfully complete treatment by DOT under the supervision of the panel physician, and then their travel clearance is valid for 3 months from the final culture. And we're going to get to that, but there's always one culture taken at the end of treatment. So they would be at least 3 months after treatment before they could travel. Let's get to the Class B1s. This is the largest group that we tend to see. So the Class B1 TB is individuals who have signs or symptoms, a physical exam or chest x-ray suggesting TB, but their smears and cultures are negative, and the applicant is not diagnosed by the panel physician as having active TB. Patients diagnosed with TB disease who refuse DOT by a panel physician, are required to wait for a year and then can return for another evaluation. So if they come back after a year and they still they can come back for reevaluation, but obviously if the panel physician feels like that person still has TB disease, they still need to be treated. So, but if after a return, it does not look like they have TB disease, you have collected the sputums and they are all smear and culture negative, then that person could be given a designation of Class B1, and their travel clearance would be valid for 3 months from the final culture. Class B1 extrapulmonary, these are individuals with extrapulmonary TB with a normal chest x-ray and negative sputum smears and cultures. Again, travel clearance is valid for 3 months. Now, Class B2, these are individuals, and these would be your children who are ages 2 to 14. They have a positive IGRA or a TST if they're under 2 and you use the TST, but they're otherwise have a negative evaluation. That means all tests, if there was more than one, also have to be documented. If they were a contact to someone with active TB, they would get a Class B3 that we'll talk about next as well. But that travel clearance is valid for 6 months from final culture. So again, basically positive IGRA or TST, otherwise negative evaluation. But you do need to make note whether or not they are a contact to someone who has active TB, and they're good to travel for 6 months. So let's talk about the contact evaluation. These are individuals with recent contact to a known TB case, a TB disease case. So this might be one of your other patients, but it may just be a household member who is not looking to immigrate. But regardless of what their IGRA or TST result is, you still need to designate them as a B3, because maybe it takes on the average about what's known as about 2 to 6 weeks after an MTB organism is inhaled for one of the screening tests to become positive. So in the US, we screen after the last known contact with an individual who is infectious, we screen 8 to 10 weeks after that. So the individual may be looking to immigrate in that window period. So it is important that the paperwork come over that they have had, that they are a known recent contact to someone who has active TB disease. They must have an IGRA or TST result documented. If we look at when we receive them in the US, if we look at when that test was done versus when the last known contact was, and if it hasn't been 8 to 10 weeks, we will screen them again when they come, so we know. The information about the source case must be provided. Very important if the source case has evidence of drug resistance. That would be really important information for the individuals receiving your applicant and their ability to appropriately treat them. So travel clearance is valid for 6 months from the final culture. If they've had a culture taken, that probably should be off back here to the LTBI. But if they have cultures grown for any reason, you have some concerns, then it would be 6 months from that final culture that they can travel. And then anyone with classifications pending, any studies that are deemed necessary, must reach a conclusion about the presence or absence of TB disease. You have to rule out active disease before the person can travel and have anything else pending. So keep in mind that applicants can be a class 1, which is, someone that you were suspecting, or you did a workup for TB, they had signs and symptoms, or they had a chest x-ray finding, and they can be a B3, which is someone who is a contact to someone. So remember, they can be a B1 and a B3, or they could be LTBI after your workup, no evidence of disease, but a positive screening test, an IGRA or a TST, and be a contact. So just keep in mind that those ones you can have two different designations for the same individual. So applicants with sputum smear positive for AFB cannot be cleared and should be started on treatment for TB disease. So what do you do if they're smear positive, but the cultures return negative? So if the cultures finalize negative, then the panel physician should use their judgment to decide if treatment should be continued. So if you feel pretty strongly that this is the individual has active TB, what your findings from their history, from their symptoms, from their response to, you started them on treatment and they had a very robust response to treatment. All of this suggests that maybe something happened to your cultures. I always say that, whenever their human error can be part of the equation, you can't ever say for sure that something didn't happen to one of the patient's specimens. But if you feel that that person has active disease, you should finish the treatment for active disease. Now, if the cultures grow NTM, then again, you should use your judgment to determine if treatment should be continued. So if they, start off smear positive, you have started the treatment, and the treatment course is more consistent with a non-tuberculous mycobacteria. The patient never had really systemic symptom to suggest TB, and nothing changed on anything else about the patient, the imaging, et cetera, or it looks like a contaminant, then yes, by all means, stop the treatment and reclass the patient. So applicants with negative smears and positive cultures, though, cannot be cleared and have to be treated for active disease. So for individuals with extrapulmonary TB, this is extrapulmonary, but excluding laryngeal, pleural, intrathoracic lymph nodes, and lung parenchyma. Any of those regions in the body are considered active TB disease and have to be treated. So if they have extrapulmonary TB and a chest x-ray that suggests TB disease, they should be treated for TB disease regardless of what you see on the smear and culture results. So that is one of the questions that I think that the panel physician submitted, asked the question, if the person grows NTM, and can they travel? Then the answer is, if they have no other evidence that they have active TB disease, yes, they can travel. So with a normal, if you have extrapulmonary TB with a normal chest X-ray, negative sputum smears and cultures, you can be cleared for travel. That's considered a class B1 TB extrapulmonary. Okay. And then a patient should be considered for treatment with DOT if they're not traveling in the next 3 months. So if they're not going to travel, would seriously consider treating them while they're stateside while they're in country before they progress to active disease. Otherwise, then it is recommended that they have reevaluations every 3 months. So applicants with a single contaminated sputum specimen is the worst. You send your 3 specimens and one of them grows a contaminant. And then, so the question would be, do you have to start all over again? And the answer is no. So applicants with a single contaminated sputum can be cleared to travel, but if there are 2 or more contaminated specimens, meaning they only have likely 1, then 3 more specimens should be collected and resulted before the person is allowed to travel. And something that just popped up in the box, Dr. Smith, as one of our speakers points out, extrapulmonary TB disease is disease. It is just not contagious. And so in the beginning, when I pointed out that the whole point of the TIs is to prevent infectious individuals from entering the country, but all of the documentation that you do and all of the things that we see when we receive the paperwork on our end helps us protect the patient from progressing to becoming infectious, to being able to treat those individuals while they're still non-infectious and before they become a threat to their family. So more on classifications and travel clearance. Applicants that are diagnosed with TB, active TB, who refuse DOT are not cleared for travel. They must repeat the screening 1 year after the non-sanctioned treatment. So if they don't want to be treated so that you can document that they received adequate treatment, they're required to wait a year. And so the question is, why a year? I think there's a balance between picking an amount of time that's fair and also picking an amount of time that might, if the person has inadequate treatment, allow them to progress to a point where you would be able to diagnose them. So if their exam is negative, if after the year of the non-sanctioned treatment, the exam is negative, they can be cleared for travel and as a class B1 pulmonary. For applicants less than 10 years of age who require sputum analysis, they can travel with smears that are negative. You do not have to wait for cultures unless they have cavities, extensive disease, and a forceful cough, or were in contact with an MDR case. In those cases, they need to have further evaluation and treatment before they're able to travel. But if they're less than 10 and you are doing your physical exam, you're doing your history, you hear something and you do a chest x-ray and you see something, and these are all suggestive of TB, you can collect your specimens. But if that child less than 10, again, children less than 10 are generally less infectious. So if they're less than 10 and you get 3 smears negative, then you can let that child travel. And that child travels as a class B1 TB pulmonary. And you have to document that the cultures are pending so that the evaluating physician receiving that child will also be aware, but you also need to email DGMQ that the results when they're available so that they can be passed on to where the child is in the US. TB treatment. TB treatment must be based on US treatment guidelines and must use quality assured drugs. So they must be by DOT. So directly observed therapy, the individual can come to the clinic and take the meds daily, but this is a service that has to be provided by the panel physician, or they must identify someone in country, that in-country treatment program that the panel physician is comfortable being responsible for. but it must be assured that that individual actually does get treated by DOT, and it is a responsibility of the panel physician to assure that this happens. So either the panel physician can have in their clinic available for the patient, or if they have treatment programs in country that they're willing to take responsibility for them getting it done, that can be done as well. So the panel physician must report any applicants who refuse treatment by the panel physician, and also whatever other arrangements were made, and what the panel physician's comfort level is with the arrangements that were made. So that's where, remember, if you have someone who does not absolutely want to be treated by DOT and does not want to work with the panel physician to get treated, then that individual would have to wait a year and come back for a reevaluation after the end of the evaluation period. After that would be a year after the non-sanctioned treatment. So applicants with rifampin resistance must report to be reported to DGMQ within 1 week of receipt of the DST report. And the panel physician must request a consult from the Centers of Excellence. And so we are 4, and I'll show the button where you go to find us, but we're always really excited to work with the panel physicians overseas, very dedicated bunch. And it's a pleasure to have the opportunity to work with them in managing their patients. So if the panel physician does not treat a patient with rifampin resistance, they must follow their treatment and alert DGMQ if it does not meet US treatment requirements. So this is just more of the same that, as I was saying before, the panel physician, basically if they're not the ones who are doing the treating, whether the patient has rifampin resistance or rifampin susceptible disease, there's still they're still required to make sure that that person gets to treatment, or to alert DGMQ that the individual did not want to comply, or I will say did not want to work with the panel physician on treatment. So here, just wanted to add here, down here on the bottom right is the button where you find on the CDC page on technical instructions for panel physicians, where you can go for to be put in touch with the Centers of Excellence should you have a question. And the requirement for patients who have rifampin resistant disease, but basically if you have a very complicated patient that you have some concern about, you can still hit a request for consultation there. So waivers. So again, this allows applicants undergoing pulmonary or laryngeal TB treatment to petition for a Class A waiver. And the panel physician should provide all available medical information to the CDC, and with a summary, and basically the Department of Homeland Security will make a determination. There are some individuals that, for safety's sake or for other reasons, may need to travel a little bit faster than their paperwork will allow, and so there are provisions for being considered for a waiver, but it's just the job of the panel physician to provide every nugget of information that we can get for that person. Treatment monitoring. So again, treatment must be based on US treatment guidelines. So that is the most important. So culture positive, but rifampin sensitive treatment, there's a requirement for 2 sputum specimens to be collected monthly for both smear and culture during treatment until there are 2 consecutive cultures that are negative. That is the same that we do here in the US. That happens in every health department in the United States as well. And this is looking for when the person makes conversion of their cultures to negative. There are also requirement for 2 sputum specimens be collected for a smearing culture at the end of therapy to make sure that the person actually did convert and maintain sputum and smear and culture negativity at the end of treatment. So for those who are for culture positive but rifampin resistant, then there's only a requirement for 2 sputum specimens collected monthly during treatment as opposed to twice monthly. No, excuse me. So this is the same, sorry, both for both rifampin sensitive and rifampin sensitive, you have to collect the specimen monthly. Pardon me for that. And then you have to have 2 specimens collected for smear and culture at the end of treatment. So again, pretty much the same, but if there are no drug susceptibility results, you're going to do 1 sputum specimen monthly for smear and culture just at the end of treatment. So assuming that there was either culture negative or contamination, but there was a good effort to get good quality sputums in the beginning. If there were never any sputum that resulted, you still have to get 1 monthly and at the end of treatment. So 2 for those who actually are culture positive, you will get 2 specimens and you will get them monthly. And then you'll, at the end of treatment, everybody gets a specimen sent for smearing culture. So now contacts of TB cases. So a contact is a person who has shared airspace with a person who has smear or culture positive for TB for a prolonged period of time. This is this is some subject for debate because, you know, the question of days, weeks, it's usually not minutes, hours, but in small children, if you have the most susceptible host is basically a child under a year of age. This is a child these children are at the highest risk. And so if you have someone who is, you know, strongly smear positive, who held a newborn infant, their grandbaby, their grandchild, or you know, an elder just spending some time holding a small child, that child probably has had significant contact. So generally it's not minutes or hours, but a lot of that depends on the susceptibility of the host. So, but it's important, more so, the more compact, the closer the exposure, et cetera, all things need to be considered. So applicants who are contacts must be evaluated for TB disease by the panel physician and must receive an IGRA, or a skin test is allowed in children less than 2, but they will have to have one or the other. Everyone over 2 years of age will have to have an IGRA, but you can use a TST if they're less than 2. So if the IGRA is negative, or for small children, the TST is less than 5 millimeters, which is also considered negative. If the chest X-ray is normal, if indicated. So if you see any signs or symptoms of disease, remember a chest X-ray is required. And if there are no clinical symptoms of TB, no known HIV, then that individual can travel immediately. So this is the class B3. This is a TB contact evaluation. So if you're traveling, if they're traveling less than 8 weeks after the break in contact, that's a class B3 TB evaluation. So that means that when they get to stateside, they need to have that test repeated. So if no traveling is immediate and no treatment is instituted, you need to repeat the IGRA every 3 months until departure, or until they reach the greater than or equal to 8 weeks after the break in contact. So again, in the US, if from the last time that person was in contact with the person who was infectious to 8 weeks later, then that's what we consider the window period when, in general, in the US, we would start a child on treatment. If the child immigrates to the US sometime before that 8 weeks, and there was a strong enough indication that there was contact with an infectious case, we may start the child on treatment here in the US. But we need this information that you provide. So remember, this is a class 3 TB contact evaluation. If they're traveling less than 8 weeks after the break in contact, that would be the designation that we would be looking for. And if they're not traveling immediately, again, no travel treatment is, and no treatment is instituted, then you want to repeat the IGRA every 3 months until they depart, or until greater than or equal to 8 weeks after departure. So 8 weeks after the break in contact is basically 2 months. But if they're still in contact with that individual, then you want to keep testing to make sure that they don't convert to positive. If the screening test is negative, greater than or equal to 8 weeks after the break in contact, there is no B3 designation. because you've completed the screening for that person. Now, if the IGRA results positive, so they have a TST greater than 5 millimeters, or the IGRA result is positive, they must have further evaluation. You want to have an exam, a chest x-ray, and a symptom screen. So if any of these are positive, that individual must provide sputum. So if it's a child, you want to collect gastric aspirates. If it's an older child, you want to try to collect sputum. But if they're diagnosed with TB, they must be treated. If the sputum is negative and smear negative, then there was still something. Remember, initially you collected sputum because there was a symptom screen or a chest x-ray finding, then they would become now a class B1 pulmonary and a class B3 because they were in contact with someone else, and you would need to provide the information on the source case. So if all of the evaluation is negative, but their IGRA is positive or their TST is positive, you would still give them a class 2 LTBI evaluation, but don't forget the B3, because again, they were in contact with someone and likely converted. So if there's no treatment and no immediate travel, you have to evaluate them every 3 months until they depart. So for children less than 4 years of age, so I had a question, one of the panel physicians asked the question, is LTBI treatment a requirement? And the answer is no. It is not a requirement to travel. So children less than 4 years of age and applicants with impaired immunity who are contacts to a known TB case. Preventative therapy should be initiated overseas. After TB disease has been ruled out in children less than 4, then that means they have not reached 5 years old. Once they reach 5 years old, that is not a requirement. But if in the instance of children less than 5 or anywhere 4 years of age and less than or equal to 4 years of age, then preventative therapy should be initiated overseas. This is after TB disease has been ruled out and they have been shown to be in contact with an infectious adult. So you should start DOPT regardless of results of the screening test. You can stop, treatment can be stopped if the IGRA TST is negative after the 8 weeks. So again, the screening after 8 to 10 weeks, if they're screened negative, you can stop the directly observed preventative therapy. So if the applicant does not complete DOPT, they may be cleared for travel while on preventative therapy, but then you're going to class them as a class B3 contact evaluation. So that we'll be looking for that on our end. And they should receive a 30-day supply of medications and instructions on how to take them. And then they will be reevaluated when they reach the US. So getting to the end, the documentation. So really the documentation required chest x-ray findings and images, the IGRA results, sputum AFB smear and culture results, and cultures for mycobacteria, if they resulted as NTM, need to know that as well. But if they resulted as MTB, and then culture, and then the repeat cultures after the person completes treatment. Remember all of those. And then drug susceptibility test results, directly observed therapy regimen, what the regimen was, and that the panel physician is confident that it was not only implemented, but completed, and then the clinical course are all requirements. So that was a whole lot of talking, but in conclusion, the technical instructions are a key factor for success of TB elimination among immigrants that are screened overseas. And I cannot emphasize enough, the panel physicians play such a vital role in the care of these patients. And what we see when we receive the patients on our end and the care that they have been given, before they leave their country. And the care provided by panel physicians is based on the US guidelines and are compliant with the CDC and ATS standards for diagnosis and treatment of TB. And just again, to reiterate that it is such a huge part of our being able to care for our patients that immigrate here, and our new citizens when they arrive, and being able to make sure that they are all seen to and taken care of. So I would like to end my talk with a thank you to all of the panel physicians and for what they do every single day. And then we'll open up to see if we have any questions. Stop sharing.
Dr. Armitage, so it looks like we have 10 questions in the Q&A.
Okay, let's see. Here we go. Can you take sputum samples with more than 24 hours between one sample and another? For example, one on Friday and the other on Monday and Tuesday. That should be allowable. What it says in the TIs is that the preference is that you have 3 consecutive days. But I think everybody understands for the weekend, and really you want to start getting a person evaluated frequently as soon as possible. You know, individuals are trying to either get their paperwork together to go, or you have some concerns that they may have disease, then having delays, just to get 3 consecutive days seems kind of silly. So to answer your question, my understanding in the reading of the TIs is yes. If you have a separation by a weekend, then that's probably no problem. But you really, as much as you can, the preference is to get them 3 days in a row. Is there a consideration to remove streptomycin from the first-line DST panel since it's no longer part of the first-line TB treatment regimens? That's a good question. It's still in the US screening. There's still many labs that have that still have the streptomycin in it here. So I think we're going to start seeing most of the injectables start to come out eventually. I think that's an excellent question, and I think that's something that we're probably going to start seeing. So since most programs are moving toward an all-oral MDR regimen, the current second-line DST panel only ends up giving information on the quinolones. True. Is there room to revise the panel to include the newer TB medicines and remove those that the World Health Organization has advised not to include in the drug-resistant TB treatment regimens? I think we're going to have to keep some of them. I think I would love to tell you that 100% of the people are going to be able to tolerate every drug in the all-oral regimen. I think there are enough drugs and there are enough new drugs that you will see that the transition should be coming on fully. And I think I think most of the injectables will in all likelihood start to come off. But the problem is there hasn't been enough experience with the meds, and you want to, when you do a drug panel, you want to know that you feel pretty confident what is considered susceptible and what is considered resistant. There haven't been a lot of drug resistant organisms with the new meds yet for us to have a clean breakpoint between this is susceptible and this is resistant. It's coming. There's a lot of push to get that done, but I think it's going to take a little bit more time as things roll out for as the regimens are used more and more. I think we'll see that there'll be more information developed for DST. But I think the injectables, I agree. I mean, I think it's just time to let those go. I think they need to come off. What class do we assign an applicant who has initially B1 TB with an abnormal chest X-ray, negative sputum, and then returns for a repeat exam because they did not travel, especially if the X-ray on the repeat exam is normal? I would say if the repeat exam is normal and all of your other assessments are normal as well, the fact that they were a B1 at some point, I would have to leave that to the folks at DGMQ. And any questions that I can't answer, I'm going to ask Delfino to flag that one. I will try to get the answer for you and send it out. But I would think that they would still be a B1 because at some point they had an abnormal chest X-ray. And even though the sputum was negative, that probably when you want to repeat, you'd want to repeat with the understanding that they had an abnormality before. But I think if there was one note that if the person was treated previously and then returned and their chest x-ray was negative, you could get them as basically a no TB designation. So let's see, our B1 patient on US side usually don't bring their chest x-ray for comparison with films taken in the US. Is that pretty standard? It would be really helpful. That's one of our US physicians. I think they're working on having the images uploaded into the portal. They're trying, like we're trying to get there, because I know that the panel physicians are working really hard overseas and getting it done. I think there's just a disconnect between what they're able to get there and what we're able to see that they've done when they get here. In reference to a B3, it would be really helpful to define recent TB contact in the past year or 2 or 5. I agree. That's and I've heard, I have a Dr. Dimitri, whoever you are, thank you for your questions, because there's some really good questions. We haven't really been able to decide on recent TB contact here in the US. That's such a vague statement. And I think it gives you some room to, as a physician, ask yourself, how close was this person? How, if he, it's hard when unless you can be inside someone's house and see what the ventilation is in that house, or have the person describe it to you. But there is not, if we're saying recent, if the person is still infectious, that would be recent. But if the person has been on treatment and it's been a year, that's a harder question to answer. So is the validity for B2 and B3 6 months from final culture a clerical error, since cultures are not required for B2 and B3? Let me check that. For B2, it's only required if they're a B2 extrapulmonary, then yes, that is a requirement. So for B3 though, unless they have signs or symptoms of TB and a positive screening test, then you don't need those. But if they do have signs or symptoms of disease or chest x-ray abnormalities, when you do the additional testing, they do require sputum, and it is 6 months after the culture is finalized as negative. So is VDAT now acceptable? I'm not sure that the TI specifically addressed that. There's a lot of, I noticed that the updates happened in October of 2019, and this was right before COVID. And there's been a lot of things that have been more acceptable now, given that we had to make some changes. So I'm guessing that VDOT may be acceptable, but I would like to see, I'd like to hear from DGMQ that they are specifically saying that that is something that you can allow. But I know that we had to have a big change here in the US. And I know that overseas, a lot of our colleagues, overseas had even more, had even better success and even better, had much more aggressive approaches to it and did really well with it. So the answer, don't know that one. I'll ask Delphina to flag that one too. So please clarify how we can assign an expiry date for the medical exam of a less than 10-year-old who travels while cultures are pending. Let me see. Go back to, okay. Sure. Okay, so if you have a less than 10-year-old and you're suspecting that they have active disease, and for whatever reason, you feel like you need to collect sputum, either a sputum or a gastric aspirate. So if you have an adult and you have collected sputum on them, you have to wait for that sputum to result as negative. So regardless of what the smear shows on an adult, 15 years or older, who now has an abnormal chest x-ray or who has extrapulmonary disease, you have collected sputum, you have to wait for that sputum to finalize, smear and culture negative. Or if they're smear or culture positive, you have to initiate treatment. And they either have to have a complete course of treatment, or if the sputum cultures result negative, then you have a decision to make as the panel physician. With children, that's a little different. So if children are less than 10, that, as I said earlier, where all of the TIs are focused on catching people who may be infectious. So if a child is less than 10 and they are smear negative, even though you felt compelled to collect respiratory specimens from that child, if their smears are negative, they can travel, unless if they have cavities, they have extensive disease and a forceful cough, or they were in contact with an MDR case. Those are the 3 exceptions. But other than if you have a child less than 10 and they don't have cavities, don't have a lot of disease and cough, and we're not in contact with an known MDR case, that child can travel. And you would document them as a class B1 TB with pulmonary, and then document that the cultures are pending and let DGMQ know when they're available so that the providers on the US side can pick up the care of that patient. Hope that was clear. And let me see. Do we take 3 gastric aspirates or a BAL as one sample divided in 3? No, it needs to be, I would say you can do 1 BAL, but I think they will allow that to count as 3 respiratory samples if you get a BAL, but really I would, whatever fluid you put down into lungs, you never get 100% of it back. So the specimen after that person wakes up and sits up straight is like a pot of gold. So I would really consider, if you have to resort to a BAL, and we're talking about children mostly for this session, but if you had to resort to a BAL in a child, I would strongly consider getting gastric aspirates the next 2 mornings to see if whatever you've loosened up in the lungs can work its way into a gastric specimen, or just try to induce sputum. But you can't divide the BAL into 3, that's cheating. So I missed the beginning of the presentation. So if this was answered, I'll go back and watch. Are there any special considerations and challenges in testing LTBI in pregnancy? We haven't really addressed that yet. We're going to have some discussion on pregnant ladies, but basically no. Testing for LTBI, there's some literature, but it has not kind of come out as a clean recommendation that either of the tests is more consistent in pregnant ladies. There seems to be some drop in reactivity to some of the TB screening tests the closer it gets to delivery, and the thought is that there's a decrease in the immune system in general, trying not to reject the baby. So you may see a decrease in in the absolute numbers associated with a quantiferon, but there has not been any data to suggest that pregnant ladies should be screened any differently. So recommendations would be the same. If you have a pregnant woman who is a contact to an active case, she should have an IGRA. If you do your exam and you have some concerns about signs or symptoms, you should collect sputum and get a chest x-ray. So, and the only thing that I added is that chest x-rays in pregnant ladies are safe. So, and Joaquin Cervantes, thank you, Joaquin. I pilfered his data earlier. And correct, B2 is only TB infection, positive IGRA. If the chest x-ray is abnormal, then the applicant is now a B1, no longer a B2. So the validity of the exam at 3 months after culture results. Okay. And how could pregnancy impact the results of the IGRAs? Sorry, I didn't see your thing. Considering the altered state of the immune system, this is a new area of study. We have not given a lot of attention to our pregnant ladies like we should. So I said, is it possible to get a false positive due to pregnancy in a low risk US-born person who could then go on to test negative postpartum retest? I think in any pregnant lady, you should be a little bit suspicious. If there's any chance that the pregnant lady may have been somewhere, you still have to be somewhere where TB is. You still have to be in the airspace with someone who may have, who may have put an organism into the air that pregnant lady could have inhaled. But I think the most important thing is to not be fearful of testing. It's very easy to just say, well, we'll just wait until the pregnancy is over. But this has implications, like I said, for that woman, for the child she's carrying, and for the individuals around her. So if there's any chance that that woman could have active disease, then you really want to step in and make sure that you do the screening for the lady. And to one, so I'm one, and I'm kind of listening to Joaquin's Cervantes, his statement. So if you do have let's just say you have a class 2, and you have a class 2 that you're working on LTBI evaluation or contact evaluation. So these individuals would, if that, it would be a class change. So if for some reason you have brought them in for evaluation, and you have some concerns, and then you have now collected sputum, I'm calling them a B2 and a B3 and saying that 3 months, clearance was 6 months from the final culture, but really they would move to, if you really had some concerns and collected sputum, you would probably reclass them as a class B1, either pulmonary or extrapulmonary, once you collect the sputum. So it probably is a typo. I'll go back and check that. But they have travel clearance. If you, the travel clearance for both the B2 and the B3 is for 6 months. Otherwise, after that, they have to be reevaluated. So I'm hoping to clear that up. It looks like that is the most of our questions. We have a couple of our
Dr. Armitage, I'm sorry.
Yes.
There's 2 questions in the chat box.
Okay.
Let's see, this is from Virgil Dennis. Any pointers recommended in the decision between gastric lavage versus bronchoscopy in eligible candidates? Both, I assume it is 3GL versus a single bronchoscopy lavage.
Yeah, that's a good question. So the question being about three gastric lavages versus a bronchoscopy. A bronchoscopy, the one thing about that is it lets you get in there and get to one specimen and get to one section of the lung. If you're trying to evaluate, one thing, the gastrics give you 3 additional, opportunities to collect specimens. I don't know if you remember the study that I showed you. 3 gastrics produce just slightly higher percent of positives than 1 single BAL did. If you were going to ask me, I would say do the BAL and then get the gastrics the next morning or very shortly thereafter. That would be my recommendation. But I think some of it is what you have available to you. If you can get 3 gastric aspirates, that's 3 times that the specimens from the child's respiratory symptoms or the other individual's respiratory symptoms are pooling in their stomach, and you're collecting those. So that's 3 opportunities to get a specimen. But a single BAL, like a single lavage, if you're able to target just the section of the lung where you're seeing the disease and collect them, may actually give you a higher yield. But on the study that I showed, they were very close together. I think it would depend on what you feel like you can get most cleanly, and what in your hands seems to be most accurate. And I'm sorry, Delphine has the other question.
Yes, so there's one more. It says, are we looking at Gene Expert NAT to replace cultures anytime soon?
Or are we looking at Gene Expert?
And then in parentheses, NAT and AAT to replace cultures anytime soon?
I would say not likely. I think the NATs are the sensitivity of the NATs is a beautiful thing. I mean, it actually, you see that this is a really important addition to what we're doing. But the cultures, until we get to a point where we can get susceptibilities without the cultures. I think you may in the future see a point where you can detect it by gene expert, but you have to grow it, and then you have molecular testing to get your susceptibilities. I think that may be a future we're moving toward, but I don't see a point at which we would not have cultures so that we could do susceptibilities on the organism. It would have to be a really, really sensitive test that could detect all the way down to not only telling us if MTB is present, but what the susceptibilities are. I don't think we're close to that yet. All right. Well, I want to just say, like I said, I want to just say thank you to all of the panel physicians. I know that a lot of you are in places and all over the globe, and I always laugh about somebody getting the 5 to the midnight to 5 a.m. slot. Hopefully none of you is up that late, but we do appreciate what you do and having you here, and look forward to being able to present some really knowledgeable pediatric TB specialists, being able to bring forward the rest of the data to you.
Thank you so much, Dr. Armitage, for that wonderful presentation and for everybody's participation.